What's up? Happy Friday. What's going on, everybody? For those jumping in, happy Friday. Hope everybody's doing well. Happy New Year. Welcome to our Friday Q&A. What's happening? Ask me questions. Anything that you guys have been sitting on for the last couple weeks or so. Welcome back in. For those of you guys that are new, Delta Motion, hello, everybody. Hope everybody's doing awesome out there. Good to see you on. Happy 2022. Here we go. So I open this time and open this floor to you guys. I want you guys to just say, hey, you know what? I have a question on X, Y, and Z. What can I do? When should I do X, Y, and Z with a client or a patient, depending on what population you work with. So, like I said, asked on Instagram, ask your questions away. On YouTube, go ahead and do the same thing. I'm happy to answer whatever you guys have, right? So one question I did get, and I do get often, is kind of the how many different exercises do we need to do in the gym or whatever. So one of the things that we look at is, really for optimal results, there are various progressions and various exercises that may be more beneficial depending on what phase you're training in. But really, it all comes down to similar motions, right? Like a chest press pattern is kind of the same whether you're doing it on a barbell bench press, a floor press, a stability ball press, a push up. It's all kind of the same motion. Same with your pulls, same with your legs. Really, hip extension, knee extension, plantar flexion of the ankle, all ends up being the same. So really, exercises aren't that. You don't have to switch them up, or you don't have to have this huge like variation. Every single session has to be something different and completely unique. You can kind of stick to the same patterns to get the results that you're looking for. So I do get those questions a lot, both from you guys and from outside. So if that's something more you want me to talk about, feel free to ask away. But I got a good one here. If someone's wearing heels most of the time for work, their gastroc would be more or less not necessarily in a concentric phase, but they would be in a shortened position. So if they're not actively contracting, right? That's where that concentric phase would come into play, but they are in a shortened position. So what happens is they get adaptively short. So that connective tissue, that muscle tissue starts to kind of gets, lack of a better term, kind of gets stuck there. So one of the things that we run into is you would want to make sure that that person, if they are in heels most of the day, 8 hours a day, and then they come to train to the gym, when you do your assessment on them, more than likely you're going to see lower extremity dysfunction. So feet flatten, feet turn out, maybe knees bow in, knees bow out, excessive forward lean when they're kind of standing. But if you do the modification, maybe those improve. That gives you that like solid information that yes, they do indeed have some lower extremity dysfunction. Then yeah, we would go and approach that as release gastroc, right? Try and maybe mobilize that ankle joint. Maybe being stuck in that plantar flex position all day has done, really restricted that joint range of motion. So maybe do some joint mobs if you can, or self-administer mobilizations, and then do some lengthening to help kind of regain some extensibility there. And then you'd want to hit the opposite side. So you'd want to start with the tibialis activation, tibialis anterior activations, some of the dorsiflexion stuff that you might have seen if you're a member on the website, or if you've seen some videos. That would be, kind of my first step. That would be their quote unquote warm up, right? And when you think about this, right, you do that release technique, you do some joint mob, you do their stretching or their gastroc lengthening, and then you do some activations. That tends to kind of get people, sweating a little bit, breathing heavy, right? So that's kind of the idea of that warm up, right? So that just puts them in a better position than go do whatever it is they're going to do, right? So they're going to go do leg day or arm day or back day or chest day or whatever their total body day, whatever their plan is. But you take that 5, 10, 15 minutes of that warm up and you just put them in a better position to be successful in their routine. Miranda Pilates, best exercise for hip mobility. Um, Again, we have to go back to why, right? So why do we want to improve hip mobility? Have you done an assessment to show that that person is indeed lacking hip mobility, or that they need to regain some extensibility? If you're just going like, I feel tight, your feelings of tightness, that is not a reliable sign or a reliable assessment to use for I need more hip mobility. Unfortunately, I do find, not picking on anybody here, but I do find yoga, my yogis, my instructors and individuals, and dancers, they tend to be hypermobile. So we want to be real careful with that. So those that are hypermobile don't need more hip mobility or any more mobility for that matter, even though they may feel tight. So this is where we have to really fall back on, we need to find a reliable assessment that shows that we do indeed need more range at whatever joint we're talking about. But to answer your question, um, and like I said, not picking on anybody at all, just kind of want you to be aware of what I see most often. But to improve hip mobility, we kind of got to run through that same gamut that I was just talking about with the ankle. So, if you found in their overhead squat, they have anterior pelvic tilt, excessive forward lean that's coming from the hip. If you have some sort of those restrictions, knees bow in coming from the hip, right? And we have identified that we need to improve hip mobility. Start with releasing, right? You got to start with the releasing those hip flexor. That the hip flexors would include your rec fem, your TFL, right? Those would be the ones that you can kind of really get to. You can't really get to psoas. It's a tough muscle to get to. So like just be cautious with that one. I'm not suggesting anybody putting anything trying to get to psoas. It's just too deep. There's lots of stuff over top. So start with TFL, start with rec fem, start with anterior adductors. They're all hip flexors. Um, you also have glute min in there as well, right? So then we will go into some joint mobilizations, and there are some self-administered hip mobilizations that you can use with a band, right? So you attach a band to something, and you kind of get this oscillatory motion that will give you a little bit of this hip mobility, or I should say, will give you a little bit of this like increase in joint space, so to speak. Do some lengthening techniques for the hip. It's the kneeling hip flexor stretch. There's nothing fancy. Don't lean into it. Don't do really anything weird. Just kind of straight up and down, squeeze your glutes. That'll get that lengthening back or that extensibility back from those hip flexors. And then activate glutes, right? That's kind of what it comes down to for hips. So it's release, mobilize, lengthen, kind of that anterior hip complex, and then activate the glute musculature, glute max, glute med. That would be your best solution there. So hopefully that's somewhat helpful. Um, if not, let me know. Talk to me some more. Let's see. How can you jump? How can you improve your jumping for volleyball? If that's, I think that's what you're talking about. So jumping, right? So the best way to improve jumping is to jump, but also incorporate some. Go through that periodization-based model of stability, endurance, develop the control, develop the eccentric control, right? That deceleration component of that jump as well, right? But start with that stability phase, stability endurance phase, maybe go into a little bit of hypertrophy or general strength, let's call it. Don't be afraid to go into some max strength. So increasing that motor unit recruitment as a goal for max strength will improve or has some carryover to improving power, which would be jumping side of things. And then obviously go into some power stuff, right? So, but more importantly, make sure that you are obviously practicing the sport. No matter what you do in the gym, you still need to go and practice the sport itself. Just because you can do box jump in the gym doesn't mean you're going to be able to kind of transfer that over and put it into sport. So for knee pain on YouTube, you have knee pain, patella pain. What do? You go see somebody. I can't really tell you anything. I can't diagnose you, obviously, via YouTube Live. So I would suggest go see a physio, go see somebody who, orthopedic, something like that, to really get to the bottom of where that knee pain is coming from. There's a ton of different places or problems or issues that it could be. It could just be movement based, but there could be some underlying, structural stuff there. So if you are in pain, go see somebody. I'm sorry, that's the best I got. What's the best exercise for painful scapula and rib cage? Go see somebody. Sorry, it's the same kind of question. It's really unprofessional of me to try and diagnose something here, right? Like it's not the time or place. And I can't really say, hey, go do this. But then what if that makes you worse? You're going to come back and yell at me, and I don't want that to happen. So you have to go see somebody, go get somebody to do an assessment on you, and kind of go from there, right? But what we do find when it comes to scapular dysfunction or upper body dysfunction, what we do find kind of more commonly than not is levator, rhomboids, pec minor. They're all overactive. So, incorporating some release techniques for those muscles, and then doing some activation for low trap, mid trap, serratus anterior, right? If you think about serratus anterior, it connects to the scapula and the rib cage. So it may be one of those pieces that are kind of controlling or not controlling movement the right way, which may be giving you some pain. So some things to kind of think about, maybe get familiar with that upper body dysfunction piece, right? And then go into, visit somebody, go see somebody, and that way you can kind of have a little bit of an idea of what they are saying. Maybe they say that your serratus is underactive, and you kind of read that before, so it kind of makes sense to you, or clicks, or you're at least familiar with some of that. So that's kind of where I would go, and that's what my suggestions would be. Yas, boss, what's up? Happy Friday. Drop foot. Most of yeah, sorry, I got nothing. But I want exercise for drop foot. First of all, drop foot, go see somebody. It's a neurological disorder or a neurological issue. So there may need to be some further things there. So if you do have somebody with drop foot, or if you do have drop foot, diagnosed drop foot, you certainly want to go see someone, particularly PTs and people who have dealt with that before. That would be my suggestion there, right? So, sorry, can't give you anything there. Obviously, some of those exercises when it comes to neural stuff, some of the exercises or quote unquote corrective exercises that you see, may not be the best fix or best fit for you or for that person. So that's why I think it's very, very important to kind of collaborate with your healthcare professional. But yes, hopefully that's helpful. Let's see what else we got. Got you for volleyball. Weight loss and maintaining muscle mass. Barry, good question. That's the New Year's resolutioners for sure. I want to lose weight, but I want to stay jacked, right? It's tough, right? So it's kind of like a physiologically difficult, right? To lose weight or lose body fat is what I really think people want, and gain muscle mass, right? So with losing weight, it's all about creating caloric deficit. And with gaining muscle mass, it's all about caloric surplus. So you can't do both of those at the same time. Now, what you can do is you can start to decrease body fat, right? Caloric deficit, exercise, whatever, however you want to do that. And that becomes a very difficult task as well. There's lots of different options and opinions and all those things out there for the best way to lose body fat. But do it as safely as you can. Let's just leave it at that for now. But as you start losing body fat, what we tend to find is people start seeing more of the muscle that was kind of, let's call it, hidden by that excessive body fat. So I think you're fine as long as you continue to kind of work out, exercise, right? That stability endurance phase, even that general strength hypertrophy phase. Like if you can kind of start playing around with those or dabbling in those two phases, 4 to 6 weeks in one, 4 to 6 weeks in another, maybe do some combinations of supersets. I think that's going to get you the best results that you're looking for, that person's looking for. Because number one, energy expenditure has gone up. Hopefully, nutrition kind of is appropriate for that person. So they're going to start to see that weight loss or that body fat loss or that composition change. And in doing so, they're going to still either maintain or even kind of get a little bit more kind of dense musculature. So not necessarily building muscle, but at least starting to see, the fruits of their labor, so to speak, when they do their training. So I think that's kind of the best bet. And I don't think anybody would be very, very disappointed in you if they said, "Hey, I lost 10 pounds of body fat," but I think everybody's going to be super happy if everybody had that result from training or working with you, Barry. So that kind of would be my go-to, my first kind of steps. Obviously, everybody's a little bit different. Everybody responds differently from exercise and nutrition. So there's a lot of variables there, but creating that caloric deficit for weight loss or body fat loss and maintaining a periodized or programmed routine, consistency is key. That's kind of the big pieces there. So hopefully that's helpful. I know that's not an easy question to answer, so to speak. Any strengthening exercises for knee pain? Again, I probably wouldn't do anything until you get to the bottom of the knee pain issue. Like I said, there could be a lot of factors. Now, and I'm just going to put a hypothetical out there. If you do have somebody who comes in with knee pain, you do an assessment and you've identified that like they have knees bow in, right, in their squat, in their overhead squat, you see the knees bow in, or if you see, feet turn out, or if you see anterior pelvic tilt or asymmetrical weight shift or any of those signs, then you can probably go back and go, okay, probably more glute strengthening would be helpful. Maybe some VMO strengthening would be helpful. Maybe some tibialis anterior strengthening would be helpful, depending on what you saw in your squat. And more like release of vastus muscles, release rec fem, release hip flexors, release gastroc, release bicep fem, right? Maybe those are some of the little bits and pieces of solutions that you can start to, build. But again, go through that assessment, identify what you see. Don't just treat knee pain. You're destined to fail, so to speak. Make sure you do your assessment first. Really get to the bottom of that quote unquote pain. Let's see. Did I miss anybody? Cabby, what's up, man? Congrats. Get RC fit. Waving back at you. Two charms, what's happening? Hope you're doing well. Happy New Year. Quick description of the relationship between cervical spine and shoulder mobility. They are related. The end, right? So a couple months back, I did a webinar for our members on the website on cervical dysfunction. And that scapular and thoracic mobility are kind of interrelated and intertwined. So certainly something to take a look at. So we do actually have some cervical activation videos for you. So if you are dealing with some upper body dysfunction, there are some things that we can do. Some release techniques. Actually, levator ends up being a big player in the head or the cervical spine, since it does attach to the cervical spine. So levator ends up being one of these like problem muscles. So yes, two charms, you're on the right track. I know you've definitely taken advantage of things that I've said in the past with this. So yes, you 100% they are related. Right? Good question. Good question. Let's see what else I got. What else I missed? Sorry. Miranda, thank you. I'm glad that helped. Ryan, loving the content halfway to CPT and HMS certs. Beautiful, good work. Just keep plugging away. I think I think you'll no problems there. Just keep on going. Very good. I'm glad you're taking advantage of that. Frozen shoulder. Frozen shoulder is an interesting one. It's one of those like weird things that happen, just can happen just out of the blue. You just can't move a shoulder one day, or can't move an arm or whatever it might be. And then another day it goes away and gets better. And it's like no matter what you did. So that one's a tricky one. If you are a personal trainer, or really, I don't know, massage therapist, I would take that frozen shoulder person and refer out. There's really not much you can do. There's really not much anybody can do, to be honest with you. But that's it's a little tricky of a thing to happen. So, but taking away that, if they're getting back into the gym, if they're coming back and seeing you for mobility and flexibility stuff, um, kind of progress slowly. Do your releases, do your potential joint mobilizations if they are cleared or if they're okay to do that. Just be cautious with some of those things. Your lengthening techniques and your activation techniques. You can start using weights. Now, I probably wouldn't say, oh, let's go bench 300 pounds, but you could probably start using some cable machines or some TRX or some of those training tools just to kind of get that motion back into their program, depending on how long they've been out with that frozen shoulder. So that's kind of my advice with that one. It is a very interesting kind of let's call it disorder, or pathology or whatever you want to call it. It's very interesting. So I don't have too much other than like, yeah, refer out and just see what they can do. And then when they get cleared, keep doing whatever they were doing that kind of helped them and just kind of go from there. So sorry, I can't be much more help on that. So sorry. Adonis wrist range of motion tests and recommendations for limited wrist dorsif wrist motion. There are some videos actually on the website that go through various, like there's I think it's TheraBand that makes kind of like a pronation and supination and kind of movement exercise resistance tool. But there are some videos on there and kind of looking at some of the structures around that wrist and what could contribute to that. So I would kind of look at them. Again, there's sometimes that wrist is tough to deal with because there is a lot of stuff in there. Sometimes it is a mobilization or a manipulation that you need, and that's outside personal training, massage therapist scope of practice. So there's some certainly some weird things that happen in there, but yeah, check out some of those videos. I can't give you too much more than that one. Let's see. I don't have anything for varicose veins, so I'm sorry. Um, Local non-radicular lower back pain after prolonged driving, probably sitting in that position or sitting in their car. You can try maybe some of those supports, those lumbar supports for their car. Um, uh, that would probably be my best bet. Obviously, if they have to be in a car for a long period of time for their job, then that's what they have to do. Or if they have to drive to get to work for a long period of time, that's what they do. Maybe some lumbar support. Maybe if they don't want to go out and buy something expensive, maybe a pillow or something like that back there can be helpful. Sometimes that's just a little bit tricky. I would also say, hey, you know what? Maybe you want to incorporate some core TVA activation work within your programming if you're not doing so already. I would probably definitely put that into their program. Let's see. I don't have management. Sorry, Shashir. I don't have management of, obviously with lumbar S1, L5, all that stuff. Um, you can only do so much, right? You got to let the body do its thing. But I would just do what I can within my scope. So core TVA work, glute work, things like that. Scapular winging, doesn't the rhomboid get lengthened and underactive? So what happens actually for upper body dysfunction, and even with scapular winging, that scapula actually moves up, right? So you have this kind of downward rotation and anterior tipping occur, which gives you that little bit of kind of like flare out back through there. But it's still downward rotation, and your rhomboids are downward rotators, and your obviously pec minor, levator are anterior tippers. So you'd actually want to release rhomboids because they are those downward rotators. You want to release levator, release your pec minor, right? And then start doing those activations of low trap, especially for that issue. Low trap, serratus, those are going to be your go-to activation exercises. So that motion, like I said, for that scapular, just scapular dysfunction in general, what we really end up seeing is downward rotation and anterior tipping, kind of positioning there. So that's going to be our solution table is release the downward rotators, pec minor, levator, rhomboids, release the anterior tippers, pec minor, levator, and then activate the opposing muscles. So my posterior tippers and my upward rotators, which end up being low trap, serratus. That's where I would go with that. I'm not a huge fan of those like push-ups with a plus. I think that's too much for pec minor. Any of that protraction stuff probably doesn't work real well to get, even though your serratus anterior is a protractor, I'd focus more so on that kind of posterior tipping and upward rotation pattern for training my serratus. All right, let's see. Sorry. Keep on scrolling. Knees bow in, what it looks like in a clinical setting, or basically what it looks like. So when you squat and your knees start to come in, that's knees bow in, right? So when you go into that squat and you start like maybe even seeing that wobbly knee, start seeing that wobbly knee, that would be knee bow in, right? A lot of people do it. Also, when you see people do lunges, and this is what people miss a lot, trainers and people that work out, when you do a lunge and that knee kind of tracks in, that's knee bow in, right? So I see it a lot in those lunges. So be really, really cautious and diligent in keeping that knee over that second toe as that person does that lunge. One of the reasons why I hate curtsy lunges is because that kind of forces that other leg in, right? So that working leg or that front side leg, that curtsy lunge, as they step backwards, that front leg always drives in to help kind of counterbalance. Bad news, not a fan. Cool. Let's see, I got a couple more minutes. Any suggestions for SI joint dysfunction? Yes, lots of glute work, but obviously there is some manipulations or mobilizations that might need to be done for that SI, for lumbar spine, even for maybe some thoracic spine. And that would be certainly take a look at the sacroiliac joint dysfunction information that we have for you on the website, and kind of go from there. But there is, glute work, TVA work. Those are going to be my go-tos for that. Let's see. Awesome. We got great questions. Cabby, what are the ways of slowing down the clients that never want to take a rest? Good luck. Yeah, when you figure that one out, let me know. Unfortunately, we're drilled into the got to work out more, got to work out more, got to work out more, and that's not always the best situation, the best case. Sometimes you gotta reel those clients or even reel yourself back in, going like, I don't need to crush myself every single day because it's not sustainable. It's there is a point of like burnout that happens, and it kind of sets you back. So having that discussion with the client or patient of going like, listen, it's okay to not be in the gym every day. Go for a walk, go swim, go bike, go do something other than what you're used to. You're still being active, you're still doing something, but it's not necessarily the same thing all the time. Kind of one of the things I would suggest, especially here, you can kind of get outside and walk all the time, especially this time of year. So like we'll hit the gym, let's say two days, and then give you a day that you can just go do whatever you want to do. Go for a run, go for a bike ride, go for a swim, go for a walk, go for whatever, right? And that's your kind of off day. So that 2 days on, 1 day off, 2 days on, 1 day off may give them a little bit, better pace, and may give them a little bit better, outcomes. So they're doing at least a little bit of something. Now, the other piece that we can do is if we go, okay, we're going to do total body, we're going to hit it hard 2 days, and then that next day, we're going to still get in the gym if they want to, but do like a corrective exercise slash rehab slash recovery day. So, glute activation, TVA activation, foam rolling, stretch, whatever you can manage with that person, right? And they're still doing something. They're still going to get a sweat. They're still going to get a workout, but it's not as intense as what they are typically doing. So it is still giving their tissues a little bit of a rest. So those would be my two bits of advice. Um, so hopefully that's helpful. Guys, I got to run. This was awesome. Thank you for logging on, jumping in. I'm sorry if I missed your question. I'll be back in 2 weeks. So every other week, jump on YouTube, jump on Instagram. Guys, go be awesome. Happy Friday. Have a good weekend. For those of you guys that log on all the time, I appreciate it all. Behave yourselves. Go do great things.